All right, welcome to today's webinar on the Florida model, confusing issues around combining outpatient treatment and sober living in California. I'm Harry Nelson of Nelson Hardiman, and I'm pleased to be joined today by a special guest, David Sheridan, who's the president of the National Alliance for Recovery Residences, executive director of the Sober Living Network. Dave, it's great to have you with us for this webinar.
Thank you, Harry. Happy to be here.
All right, so just a general disclaimer. Today we're going to have a general discussion of the issues around Florida model, and nothing that's discussed today should be considered specific legal advice. There's no attorney-client relationship that's created by listening to this webinar, and as always, we recommend that people seek legal counsel in applicable jurisdictions before applying any of the information that we discussed here today. So our topics today are going to be understanding what the Florida model is, an overview of the issues that are coming up around Florida model, taking a look at California's approach to licensure and contrasting it with Florida's approach, and talking really about questions and questionable business models related to Florida model. So with that, let's dive right in. So first of all, I wanted to begin with the definition of Florida model. The term is used a lot. In some cases, it's treated as an attractive business model. To regulators, it's often a dirty word, a sign of something being done incorrectly when it's used here in California. So first, when we use the term Florida model, we're referring to a combination of two elements in addiction treatment. And the first is some kind of unlicensed residential setting. That could be a sober living house, transitional living, extended care. But the fundamental point is the patients are living in a residential setting where there's no license on the residence. And that's being combined with the transportation of patients to an outpatient program that's providing either a partial hospitalization program, a day treatment program, or an intensive outpatient IOP program, or simple lower level outpatient services. And generally, the selling point that proponents of Florida model use is that this structure has more flexibility to allow a step down from a more intense structured program of recovery at the beginning, when a patient a participant is starting, over time to a less structured environment as the patient progresses. Dave, any comments on the sort of the general approach to Florida model?
Yeah. One of the things to keep in mind about what we're calling the Florida model is that individuals looking for and living in recovery-oriented housing and simultaneously getting some kind of community-based service, whether it's an individual therapy or outpatient programs, is not a new concept. This is something that's really quite old, and it's also something that's been promoted by SAMHSA for many years now under the idea of recovery-oriented system of care.
Terrific. So I wanted to jump into some questions about how to think about Florida model. So one of the interesting questions is, that the Florida model, there really are three questions that any operator should ask themselves about Florida model. One is, its clinical effectiveness. The other is it kosher from a licensing standpoint? And the third is, how does it relate to reimbursement, and what are the pitfalls around that? I wanted to start with the issue of clinical assessment, and I mentioned that Dave is the president and the founder of the National Alliance of Recovery Residences. Did I get your titles right?
Oh, yeah, co-founder.
And so I wanted to talk about the issues of sort of standards. NARR's approach to as NARR is really the national the first national organization focused on recovery residences, and I just wanted to get your thoughts about, from a clinical standpoint, what are the standards? How do you think about recovery residences from an efficacy standpoint?
It's a great question, and also one that's pretty open-ended. The way we view recovery residences is there's a spectrum of residential environments and ways of having people live together. If you could think at one end of the continuum, which is pretty unstructured, would be a group of people who want to live together voluntarily, set their own rules, abstinence-based, but basically no outside supervision. And that's what NARR calls a level 1 recovery residence. The most prevalent example of a level 1 residence is the Oxford House model. very successful, widely adopted around the country. Level 2 is what in a lot of places around the country we call sober living homes. Again, the focus is on residents living together. It's housing. It's not a treatment locale. People are going to school, they're going to work, sometimes going to outpatient programs. And the thing that differentiates that from an Oxford house, let's say, is that there's some level of externally provided structure and supervision. And then when we get into the level 3 and level 4 recovery residences, we're approaching residential treatment. But the main thing that underlies all of these is that there's an intentional creation of a recovery environment, a mutual support environment. It isn't really just where people live. It's part of somebody's recovery. And they belong in the continuum because, when we talk about effectiveness, one of the things we've learned in the field over the last 20 years is one of the principal keys to successful recovery outcomes is the length of time that somebody is in contact with recovery services and recovery environments. And that kind of flies in the face of the old acute care model where let's give somebody a huge whack of services for 28 days and then hope they stay in recovery. Housing is part of the continuum. And there's a fair amount of evidence that recovery outcomes are significantly better for people that will stay for 6 months to a year in a comprehensive environment where they can get recovery support and housing and the services they need.
So, Dave, thank you for that. I wanted to just my point. I don't hold myself out as having any kind of wisdom to share about whether Florida model is clinically effective or not. But what I think a point that I want to come back to at the end, and I want to underline for listeners is I believe that anybody who's using this model, given that we're going to talk about it has serious questions about from a compliance standpoint what's legal and what's not in California, needs to be thinking about Florida model from a clinical perspective, meaning that any presentation, if there are questions raised about it by licensing, which we'll talk about in just a second, the operator, any operator who's using this model needs to be able to justify it as a therapeutically effective model, and should be thinking about this in an evidence-based way, because I think you articulated reasons why it makes sense to have an extended stay in recovery, but at the same time, I think that to the extent it's being used more as a financially remunerative model, then you're in a danger zone.
Absolutely, Harry. And one of the things that's at the center of a lot of the controversy, and we're fairly alarmed by, is that the housing component of a combined outpatient and housing solution to recovery is more or less being used as bait by a lot of people. That what's covered under somebody's insurance plan is typically the evidence-based clinical care, which in an outpatient setting is provided without housing. And so we're seeing a huge number of problems when we try to include housing without an explicit understanding and acknowledgement by a third-party payer that that's part of what's being provided.
So we're going to come back to that to talk in more depth about that on some future slides. I just want to cover the licensing piece. We're going to talk about licensing, but this is an evolving question, and we're going to talk about the way that California currently approaches it, some ways to deal with the sort of ambiguity in the current approach, and what may happen in the future. But a question that every operator needs to ask themselves is this structure that we're using, is it legal? Am I doing something that is going to put me at risk of operating a facility that requires licensure? And we're going to talk about operation of integral facilities, which is a confusing concept, but that anybody who's operating in a Florida model in California needs to understand. And then lastly, the point of reimbursement here. So we're going to talk about what services can be provided in an unlicensed residence, but this is a critical question and frankly a confusing question as to what elements of service delivery are actually reimbursable by health plans and what the requirements are for coverage. And there are some practices that we see happening in Florida model programs today that are troubling from an insurance reimbursement perspective and may be a basis for allegations of fraud and abuse. All right, so let's move forward. So I just wanted to begin with kind of the way that Florida model establishes and the use of unlicensed residents. We've talked about this in greater depth on other webinars, but in a nutshell, federal law, constitutionally, but particularly beginning in the late 80s with the 1988 amendments to the Fair Housing Act and with the Americans with Disabilities Act, establishes a very clear protection for for residents of 6 or fewer people living together who share a disability, including under both Fair Housing Act and ADA, recognition of recovery from substance use disorders as a category of disability. So there is a protection in federal law and in some states, in state law, for the operation of an unlicensed facility. That's sort of where Florida model begins. So the question that comes up is, if the unlicensed residential component is legally protected under federal law and potentially under state law, then isn't it just a matter of meeting the requirements for outpatient? Isn't there all that there is to it? And the answer is it's more complicated than that. So I wanted to get to the licensing model that California has to make sure that everyone understands it who's listening to this webinar. So California licenses residential treatment facilities for substance use, alcohol and drugs, substance use disorders. These are the definition of a residential treatment facility is a 24-hour adult residential facility. It's a non-medical category that provides treatment services. Those can include non-medical detox if the facility is appropriately certified as part of its licensure, and they provide group, individual, educational sessions, recovery and treatment planning, and other individualized services. So that's the only category of adult substance use disorder treatment facility that's licensed in California. By contrast, outpatient services are not licensed in California. There's an optional certification from the same licensing entity, Department of Healthcare Services. There's accreditations available from services like CARF and the Joint Commission that are optional, but and the only requirement, there's no requirement at outpatient certification by the state or accreditation. The only ones who are really increasingly demanding this are the insurance companies. So we come to California's approach to unlicensed services. So California, both the current Department of Healthcare Services Substance Use Disorder, SUD, licensing division, and the old Department of Alcohol and Drug Programs, took the approach that unlicensed residences, known as sober livings or transitional or extended care facilities, are permitted to operate in California as long as they limit their arrangement of services. And that is a limitation to hotel-type services. They can have food, they can have a bed, janitorial cleaning services. There can be a house meeting to coordinate how those things are going to happen, but there should be no treatment services, and certainly nothing that occurs on site should be reimbursed by insurance. So that contrasts significantly with the Florida licensure model, and this is important because there's a lot of misconception out there about what is legal in Florida. And just as an additional disclaimer, I'm not a licensed attorney in Florida. We work with a number of Florida attorneys, and we've come to understand on some level their regulations. But I think it's very important just to contrast for people in California how much more detailed and specific Florida licensure requirements are. So in Florida, the license model that's the preferred license model by the Department of Children and Families, which is the Florida state agency that DCF is the entity that licenses these facilities, is what's called a day-night treatment program with community housing. And in this model, the outpatient program is licensed, in contrast to California. And the housing is at a minimum approved by Department of Children and Families, or is in some cases licensed as congregate care facilities. So while there is a separate housing and service site, while they have the same population, the expectation of Florida is that there's a license here. And it's important to note that Florida specifically objects to unlicensed sober livings operating in conjunction with IOPs, operating labs for urine drug testing, or being paid to send clients to programs. And so, anyway, Dave, I know we were speaking, and you have some thoughts about the way that Florida operators have historically responded to this the structure of the day-night treatment program.
Yeah, what we hear from our counterparts in Florida is that this community day-night model on paper is a really great cost-effective way to combine residential services with treatment services. The reality has been that as the amount of treatment capacity has increased in Florida, a lot of providers of outpatient services are consciously avoiding seeking this license by not as closely coordinating their housing and simply offering outpatient services and the housing in other places, but not necessarily to the specifications of the community day-night license. So the license is there, it's available. The way I understand it, it's mandated if you operate in a certain way. But treatment providers have been avoiding seeking this license.
So it's also, I also just wanted to add that there are pending regulations in Florida that are apparently going to change this and broaden this and stop what Dave's alluding to and really try to get global licensing for all components. And those I think will be the subject of a future webinar focusing explicitly on Florida. But I think it's important to note that Florida has much more actively regulated this and continues to actively regulate. So, and just in relation to this point, the challenging reality is that we said on a previous slide that California has recognized the right of an unlicensed facility to be a home and provide basic hotel services. But the reality is that many sober livings are doing much more than providing residential services, right? They are, and so for example, some of the questions that we hear from regulators are questions about what happens when residences are not just providing a bed and meals, but they're imposing limits as part of the recovery process and as part of a structured recovery, taking away people's smartphones to limit their ability to get into trouble, or limiting their movements, requiring them to have a companion when they go out. All right, many programs begin with a fairly intensive regime of restrictions and then loosen them up as people progress in their recovery. Right? There's also the issue of how medication is being managed, which certainly the state of California objects to that happening in an unlicensed facility. But there are sober livings out there who are doing it, who are running labs, who are connecting and coordinating physicians and therapists. So the question, I guess, Dave, I'm curious to get your thoughts on is, when the residence is, from a NARR's perspective, what's the appropriate role of the residents in and the outpatient program in terms of the optimal recovery setting?
Well, the way NARR would view that is actually determining which of the NARR levels of support that residence is actually operating under. It's a separate legal question as to what licensure you're required to have if that's what you're doing. But let me just address a few of the things. If the residence is providing, as Harry described on the previous slide, basic amenities and the kind of support services that you would get in rental housing or a hotel. The other thing they can provide, and in fact it's good public policy that they do, is abstinence verification. Now, neither NARR nor the Sober Living Network requires drug testing, but it's the dominant mode of ensuring that abstinence is happening. The big question then comes is, well, can you bill a third party for the drug testing that's done in sober living home as part of simply verifying abstinence and progress to recovery? And our stance would be most places in Southern California, or California as a whole, sober living can't bill for drug testing. They're not a clinical program.
And just to jump in, we've done a separate webinar recently on urine drug testing, and certainly agree that the best, first of all, from a fraud and abuse standpoint, urine drug testing has to be done under physician supervision and with a physician order. So to the extent that it's to be reimbursable, to the extent that urine drug testing is being used as a verification service, it may be a good practice, but it wouldn't be a reimbursable practice if it's part of the rules of how the sober living is operating.
Right. Best practices would typically be to focus on the behavior of the resident. Is somebody behaving in a way that suggests that they're not in alignment with abstinence requirement in the house? And the next step would be simply a point of care test and a verification that is simply read the strip right there on the site. And if there's a dispute, maybe a lab verification, but absolutely not on reimbursement.
Yeah. So I wanted to turn. So some of the big questions that come up are around what are the linkages that a particular residence has with an outpatient treatment program. And you made a reference earlier to some of NARR's definitions, and I thought it actually would be helpful to just go through those and sort of understand how NARR approaches these issues.
Oh, okay, sure. In a level 1 recovery residence, the residence itself is almost always freestanding. There are treatment providers that operate some level 1 recovery residences, but it's typically almost always a tail end service. And there's for people that have completed treatment, all phases of treatment. It may be that they still need a place to live for a while. Level 2 recovery residences, inside, the way NARR looks at it is inside the residence, what happens when our state affiliate evaluates a residence. It's looking at what happens in the residence. The other thing we're looking at is, can somebody live in the residence? Are they permitted to live there and not receive any outside services? If the answer is yes, then we look solely at what happens in the residence. So it's a sober living home. If somebody can be living there without having to be receiving clinical services offsite, if nobody can live in that residence except as a client of some offsite treatment program, then we look at the combination of the two to determine what that residence really is.
It's helpful. And you were saying earlier, level 3 and 4 is more of an intensive setting that would be akin to a licensure setting in California?
Correct. Both level 3 and level 4 are really on the treatment side. You couldn't operate a NARR level 3 residence in California without a license. And you can't operate a level 4 residence anywhere in the country that we know of without a license.
Can you explain what the level 4 vision is?
Yeah, a level 4 is a residential program that offers all of those recovery support services that we talked about earlier, which is the peer recovery support philosophy, plus life skills programming given by certificated individuals, plus clinical services on site.
Oh, interesting. So that might be a subject for a future webinar. So the interesting question that your slide implicates that we have here is when does a resident's outside life involve treatment services? In other words, it's permissible for a person to be living in a unlicensed residence, and to go on with their lives, to their own self-directed lives, and it certainly is permissible for that outside life to include being part of a treatment program. The question is how coordinated they are. So that sort of takes us to sort of some of the leading edge issues, and the questions that we're seeing come up are from the state of California, from various regulators, and in the industry are questions about how the services of the residential and outpatient are marketed together, and how much they're promoted as the model. To what extent the sober livings are operating as a referral network and financially benefiting, and also who's covering the cost. And so I'd actually love to get your thoughts on these issues, on each of these issues. First of all, on the issue of marketing, do you have any thoughts about how these services should the integration of recovery residents and outpatient?
A lot of thoughts, and a lot of them having to do with how marketing of recovery services has changed in the last 5, 10 years. Sober living homes, which is what that's really our expertise in California. Almost all were freestanding residential environments that weren't linked in any way to clinical services or treatment programs. The exception being a lot of integrated treatment providers that offered sober living as an aftercare service. What we're seeing now is a lot of web-based marketing, a lot of call center marketing that is targeting people on a national basis and advertising a complete suite of services that includes treatment services and residential services without making it clear that those are two separate things.
Yeah. It's just as my observation is that I agree with you. We're seeing an explosion of that kind of marketing. We're seeing the operators should be aware that the regulators are paying close attention to what's being marketed, and we've had a number of cases that initiated based on descriptions on the web of integration of services that were troubling to regulators. And I think there's a lot of it's critical that that programs think through and get sound advice about how to promote their services and how to ensure that they're accurately describing what they're doing, what the relationships are, and not only for the benefit of patients, but also to avoid coming under the licensing microscope.
In the old days, before insurance access was widespread, we were seeing a lot of sober living homes, particularly in the high end of the market, that were marketing themselves as treatment alternatives. That you could come to this beautiful beachside city and live in our home and get everything you'd get in a treatment program. And that was illegal then, still is illegal. There are fewer incentives to do that now because you can't get sober living operators can't get reimbursed for those services, and so much of the payment stream is now moved from private pay to third-party pay. Now what we're seeing are the outpatient programs advertising that they have this complete spectrum, including residential. And the problems arise when somebody shows up, typically from out of state, and find out that their living environment is operated by a whole separate entity that has nothing to do with their treatment provider. And they didn't know that that's what they'd signed up for.
So on the issue of referral relationships, one thing I just want to highlight to everyone who's listening is there's a lot of confusion over whether sober livings are entitled to some kind of payment for actually referring patients. And I want to dispel any questions about that. Under California Insurance Code Section 750, it is a crime in the state of California to receive a commission or any kind of consideration, whether it's monetary or otherwise, or to provide a referral that leads to an insurance claim. And so anyone who is being paid for referring a patient to an outpatient program or otherwise from a sober living is taking the risk of illegal conduct. And there should be no question about that. Unfortunately, we're seeing it as a rising and widespread practice. And to the extent that anyone listening is engaged in relationships like that, we strongly advise you to seek counsel.
And that would be true if the payment is disguised as a consulting relationship or case management. They're called a lot of different things.
So the other area where we get into a lot of gray area is around who covers the cost of sober living. So in many cases, the issue that comes up that we hear from outpatient treatment programs is they have a client who needs help. The person is essentially transient or homeless based on since they've had the addiction problem, and the outpatient treatment program wants to provide to pay for a bed in a sober living. And so this involves, it's a very tricky issue. There's not a clear, the law is not clear on this. There's a risk that if the relationship is structured the wrong way, that insurance companies will perceive it as being a form of fraud and abuse, where essentially services are being paid for to induce the person to choose that outpatient program. But it involves a host of other issues that you raised, David. I would love to get your comments on.
Yeah, the paying for sober living is something that our providers, the majority of whom are independent, they're not affiliated with any kind of a treatment program, approached that, could you house this person for us, and we will make some kind of a payment for that person. Um, I'll just tell you one situation we had recently where one of the treatment clients living in one of our member sober living homes approached the operator and said, I hate my treatment program, but I want to live with you. I want to still be living here. Can you recommend another treatment program to me? And all kinds of bad things started happening around that decision. Uh, the referral to another treatment program was being treated as suspect. The program that was losing the client was threatening to sue the sober living operator for interfering in a political relationship. And all because of these fuzzy boundaries between what that individual client wanted and the way the services had been presented to her.
Yeah, it's a tricky area. I want to be clear, we're not making any specific legal pronouncement on it, but it's a tricky issue that also requires a lot of thought in terms of the therapeutic implications, but and is something that should be taken up with legal counsel, in my opinion. So I wanted to get to the heart of the issue of how the state of California is approaching the Florida model. And essentially, we said on an earlier slide, California does not require outpatient programs to be licensed and has simply an optional certification model. But so what happens from the perspective of regulators, and this predates the licensure by DHCS, we saw this under the old Department of Alcohol and Drug Programs, is that essentially if an operator is using the Florida model, the operator is at risk of being perceived by the state to be making an end run around licensure and essentially using this model to avoid the time, trouble, and expense of the licensure of a residential treatment facility. And so there's no clear law that says that this model is illegal, but I think it's useful to understand where the state's perspective comes from. And if you look at Title IX of the California Code of Regulations, which are actually the regulations that were enacted by the old Department of Alcohol and Drug Programs, Section 10508 has a provision, licensure of integral facilities, as part of its certification standards, and it basically defines an integral facility as one in which the licensee provides housing and alcoholism or drug abuse recovery treatment in the same building that is the residence, right? So there's the integral components of the same facility are treatment services and residence under the control and management of the same licensee. And this model is supposed to be licensed as a single entity. And then critically, it says multiple facility programs which do not meet the criteria shall secure independent licenses for each separate facility. The challenge, of course, is that there is no licensing structure for just being a residence without treatment services. So the point here is that this provision is far from clear about what exactly is the prohibited activity is, but the state uses this provision to take the position that anybody who's taking the different elements that go into a licensed facility and pulling them apart is essentially they're in a problematic area. And we often see that we've seen in numerous cases that the state has tried to step in and take action. We've seen denial of licensures. We've seen abatement orders, and a very active position by the state in taking these things on. I wanted to get to three specific areas where we've seen activity from the state that operators should be paying attention to. We spoke on an earlier slide about marketing, but I do think, and I made reference to this, but I want to just underline it, the Department of Healthcare Services is absolutely looking at how providers are marketing the combination of outpatient and residential. And in particular, my concern here is that if you are holding yourself out as as promoting this kind of integrated service, and you do not have a licensed residential component, you're basically essentially asking the state of California to come down on you. Okay?
Uh, I'm interested in hearing about more cases of this, but what we care about when we're supporting recovery housing is what is the potential client, the resident, the clinical client, what are they being told? What choices are they being given? And what is actually being delivered? The other thing about the integral facility area that I think is important is if you do intend to deliver those things as a single unified program, there are different rules that apply to housing. HIPAA. Does HIPAA apply in a sober living home that's housing exclusively housing clients for an outpatient program? I'd be concerned about that if I were an operator. What applies?
Very confusing. Yeah, it's interesting. There's no insurance billing going on, so the provider is not a covered entity under HIPAA, but they could be a business associate. They're probably needing to handle some protected health data as a result of their relationship with the covered entity, the outpatient program. There's also even more complicated questions about Title 42, the additional heightened data privacy restrictions. So it's a good question. Key points I think are for anybody who's operating in what would be considered Florida model. One is that there's no formal law or regulation in California about what the relationship of the business entities is, but I do think that if you are an operator, one company operating both models under the same brand, I think that this is an area of concern. To the extent that there's some kind of joint venturing or business partnership between somebody who's an operator of outpatient programs and somebody who's an operator of sober livings, I think that is a relationship that the state is less concerned about. And then I think this is really a key point is in a number of cases we've seen that the regulators are less concerned about the combination of outpatient and sober living unlicensed residential if it's in a multi-setting treatment offering where an operator is really taking a broad therapeutic approach and is incorporating elsewhere elements of licensed residential treatment or detox. And essentially, in other words, an operator is providing multiple settings and incorporating the unlicensed setting as a step down model after the licensed facility. In those cases, I think that there's a much more credible case to be made by the operator that they're not using the unlicensed facility as an end run because they have a licensed option. It's just that they're putting it at some point where it's therapeutically appropriate. And while we're not in an area where there's any law, in general, we have seen a more relaxed approach and an appreciation by regulators for the serious thought that's gone into the therapeutic options.
Yeah, I agree with that, Harry. One of the real promises of, call it the Florida model or a recovery-oriented system of care, is we can stop caring as much about what does a program look like for an average generic client and what's the best series of services for an individual. And that means through time, too. So these step-down ideas, they've been around for a long time, have the promise of delivering more targeted services that benefit individuals rather than entire cohorts as we have in a residential program. So they can stay in contact with care for longer. They can get the specific services they need as opposed to some generic bundle. And the whole thing will cost them less and give them an ability, for example, to go back to work and pay for their recovery experience sooner. So there's a lot of promise here. But the other thing that we're concerned about that gets at this, you talk about unlicensed residents and a desire to see more licensure and more rigidity, is pushback from a lot of local governments about we don't want this many people who are in recovery living in our communities. And they view that the federal fair housing protections, and in fact, California state protections are quite strong, as threats to the quality of life of their cities. And so a lot of this push for licensure and regulation is actually coming as what we hope is a misplaced belief that by defining something as a licensable environment, that we don't have to recognize the fair housing rights of the people that live there.
I think it's a great point. I just wanted to add, in addition, I think your message, I think, is very valuable from just thinking about this in a therapeutic model, but also for people who are looking at reimbursement. One trend that we're seeing among the payers is a greater resistance to residential treatment facilities stepping down people who remain in the licensed residential treatment setting from a PHP or from a residential treatment or PHP level to an IOP level of care. Specifically, we're seeing that in general, payers are reimbursing residential treatment facilities for the residential treatment level of care and also the structured housing of a partial hospitalization program. But once the person is at the IOP, intensive outpatient level of care, payers are increasingly being more aggressive about objecting to the overly structured housing that's required in a residential setting. So there could be an actual advantage for operators of having an unlicensed residence in California and stepping down a person who's really appropriate for IOP services to that residence. And this is really we've been seeing this over the last several months, and I think it's likely to continue as a trend.
Yeah, and there are some other people that are looking at this too. The American Society of Addiction Medicine is looking at their spectrum, their assessment criteria, and how they define different environments for recovery services. And we at NARR are working with ASAM right now on rethinking that pairing between what's the appropriate level of clinical services for somebody with a certain set of manifestations, and then what's the right housing environment for them. And Harry mentioned that mismatch, and it's not just the insurance companies. There's a lot of people looking at that.
So I thought it would be useful to move to some of the issues, the challenges that are coming up at the local level that we'll talk about, and also some state reforms. One reform that did not carry last year, but we hope is still on the horizon, and I know, Dave, you were very involved in this effort, was Assembly Bill 2255, which was a model that would have brought to California what's been adopted in Florida and Massachusetts, and that's a voluntary certification process for recovery residences. And I thought it was useful to talk about this because I also, just as putting unlicensed sober living and outpatient into a broader spectrum of treatment options, we believe is a better option from a lot of perspectives. I think also having some kind of state certification process for, even if it's voluntary, for unlicensed residences could be a really positive step for use of a Florida model in California.
We think it is too, and one thing that we're basing a lot of our advocacy on is what the state of Massachusetts and Florida have done in the past. Massachusetts commissioned a study in 2010 that looked at fair housing laws and looked at some of their other environmental variables in Massachusetts and realized they wanted to raise the average quality of the recovery housing they had. They didn't have standards. They didn't have an organization like NARR or the Sober Living Network. But they also realized that fair housing laws protected good and bad operators together. So what they opted to do was to create an environment where they could incentivize operators to meet an externally defined and administered set of standards. And so what they've done, and what we proposed in AB 2255 along with CCAP, was a voluntary certification standard that would be based on a national standard, would be administered by organizations recognized by the State Department of Healthcare Services. And in the homes that would be certified under that process would be recognized as being qualitatively different. They'd be subject to oversight by those two organizations, much the way addiction counselors are certified in California, where there's a third-party certifying body that the state recognizes, and there are sanctions for not doing things according to standards or violating codes of ethics. The same thing would apply to a sober living home. In return for maintaining certification, there would be some referral benefits. That a home that met all the criteria, which, by the way, do include good neighbor policies. That's part of the standard, that those are the rules that you have to follow. That if you met the standard, that after a certain point in the future, after the law was passed, that referrals from state-funded programs and state licensed programs to sober living homes could only be made to certified sober living homes. And that's really worked out well in Massachusetts, where they went at the beginning of 2016, they had no certified homes. And as we're sitting here in December of the year, they have over 125 and another 75 that are in process. So those incentives really mean a lot.
That's great. I think, Dave, I think it's an important bill that you and NARR and CAR, the California Alliance, and CCAP pushed. And I want to highlight for people who are operating on the Florida model currently, supporting legislation like this is valuable from a number of fronts. Number one, it's a way of distinguishing yourself as somebody who's using Florida model as not for some financial gain, but really to be a good operator and really to provide a therapeutically valuable service, and to distinguish yourself from people out there who may not be as intentional and as conscious of that. And with that, I wanted to turn to the other sort of legislative trend that we think relates to this issue. Last year, this was another bill that did not pass, but this was a local, very different model. Instead of a state voluntary certification model, there was a bill proposed by the League of Cities and by Assemblymen with the support of the League of Cities to essentially give local communities, cities and counties, more power to create their own structured sober living registration requirements. And this model is much more concerning to us. Just to summarize it, it basically, is part of a movement that we see of local regulations proliferating against unlicensed sober living residences, and including all kinds of requirements, including density restrictions, and all kinds of different requirements. And what's problematic from our perspective is that having a patchwork of local ordinances, as Dave, as you alluded, it's a concern from the intention of cities that we've seen historically to limit the placement of housing, and but also just on a practical administrative level, it means that operators are going to have to comply with all kinds of inconsistent requirements. We think it's a recipe for litigation over the constitutionality of these restrictions. And in contrast to the approach of voluntary certification that CAR and NARR supported, it's really a model for just a lot of problems ahead.
We think it is too. That first of all, you're under California law, local governments are not permitted to inquire about the blood or marital relationships of any adults that live together in housing. So these kinds of approaches are actively discriminating against certain unrelated people relative to the general population. And our reading of fair housing law says this is going to end in litigation and acrimony. It's already cost the city of Newport Beach over $10 million to try to institute a framework like this. A lot of cities are considering it, but it's harmful to people. It's stigmatizing, and we think this approach is bound to end in tears for everybody.
So I wanted to offer some concluding thoughts about Florida model. We obviously, what we portrayed here is a lot of what we're seeing there, but without a lot statutes and regulations that clearly establish what is and is not permissible. We hope that it's been helpful in terms of giving a perspective on the enforcement environment and how the state of California is approaching the issue, what some of the challenging issues are. But really, there's a need here for further clarification of what is expected from a state perspective of what a compliant operation looks like. And given that we've, in the last few slides, we've been talking about this tension between the treatment community, the recovery community, advocating models that are therapeutically sound and that really establish what a good citizenship looks like from the recovery community standpoint. And on the other side, you have a lot of encroachment and more aggressive requests for policing from local communities. It's an important time for operators to be part of the discussion and to hopefully support advocacy by CCAP, by CAR, by other groups to get some clarification from the state of California and to really understand what the state is going to object to and what the state views as appropriate. And I think one of the things I hope comes out of the discussion today is that there are cases where the combination of outpatient and sober living is maybe optimal. And if it's done correctly, there are cases where there are plenty of opportunity for it to be a therapeutically valuable model, and there's not a black and white question here. Instead, this is an area where some sensitivity and subtlety is needed to approach Florida model and recognize it as a complex issue. I wanted to take up one question which comes up which is whether licensure of outpatient programs is on the horizon in the state of California. From what we hear from Sacramento, there does not seem to be any movement towards a licensing in California for outpatient programs. This does put California really on a different footing than many other states, which have moved towards licensure models or have already for many years had licensure of outpatient programs. And I think that the reason I pointed out is because if California was to do more to establish licensing requirements for outpatient programs, that would offer a huge step forward of addressing this problem. Part of the problem here is that there is no requirement of licensure for the outpatient program or for the residential, making this a particularly confusing subject. Dave, I don't know if you have any thoughts on that topic.
Well, the one thing about we've opposed licensure and will continue to for things that are inherently unlicensable, like sober living type housing. But where you have professional services that are being delivered and an expectation that third parties are going to pay for it, if you don't have licensure, you create all kinds of opportunities for people to enter the market, provide inferior services, and even if they get shut down, just reopen someplace else. The barriers to the bad operators are just too low.
Yeah. So I mentioned on an earlier slide, we see the challenge of lack of state regulation is that it encourages local ordinances to feel the need for more policing, and the more that we are in a system of local regulation, operation becomes significantly more complicated. So I think that's again a reason why operators should be actively advocating and working with groups like CAR and with CCAP to ensure that not only regulators but legislators understand how the addiction treatment community and the recovery community is thinking about these issues and what's going to be best for the people who need help. And finally, as we've said, I just want to underline, ultimately, I think the best strategy with regard to Florida model will be driven by a therapeutic model that encompasses residential, whether that's happening within one entity or through some kind of partnerships of multiple operators. I think that the lesson of what we've seen from Florida model enforcement in the state of California is that it's much less of an issue in an environment where residential treatment is also part of the calculus and much easier. I don't know if you have any final thoughts, Dave.
Uh, the one final thought I have is really a hope that people listening to this get involved in the advocacy side. One thing we really desperately need is some dialogue that includes treatment providers, third-party payers, the state licensing agency, and things like recovery housing providers. That there are some really good care models in there, and we've got a lot of barriers coming from existing regulations and existing misunderstanding. And I think we can see a proliferation of really good care models if we have better dialogue.
Terrific. So I want to thank everybody for listening, and I want to particularly thank Dave Sheridan. Dave, we're lucky to have you here today. You truly are one of the champions of the fight for recovery housing and for advocacy for the rights of the recovery community. So I'm really grateful you joined us today, and I hope we'll be able to include you on future programs in the future. Thank you.
Thank you, Harry. This was great.